Good morning. It's Friday the 13th, and today I'm going to be reviewing some materials from last week's class, and I'm also going to be helping you prepare for next week's class. If you remember, the focus of last week's class was on evidence-based practice, and we spent a lot of time focusing on and conversing about language and terminology. I want to bring a couple of key ideas forward to you that seem to be, from my review of the discussion groups and the messaging, there is a little bit of confusion around some key issues. First and foremost, languages form a way of communicating about phenomenon. So we generally are looking to bring the terms that are most likely to evoke the concept that we're trying to convey into use. So for example, if we're talking about pain, that brings to mind for individuals a sense of severe discomfort, achiness, maybe sharpness. Now, we can use a lot of other terms to describe pain, like dull, like sharp, stabbing, but the concept pain is best reflected by the word pain. Now, in the conversations about the terminologies, I heard several of you using different sets of logics to apply a terminology set to a particular set of words. And some of those logics were pretty complex. So for example, someone described the process of looking at the word ASA and then thinking through the logic of ASA as an analgesic. We use it for pain management. It's used for muscle pain, and went into, or rather described, a long cognitive string of phrases to be able to map the term ASA to a specific vocabulary. That's really more complex than we need to do, and we want to use pretty simple and straightforward straightforward rules rather, when we're mapping terms to vocabularies. So in general, you should not have to do a lot of cognitive work to know that a specific word holds a particular meaning. And therefore, I want you to use the most simple semantic matching, or the concept that you're trying to describe and the word that you're trying to use. This brings up the second problem that I heard in some of the thinking among some of you. I heard several calls for the fact that nursing and medicine should use the same vocabulary. We should use the same words. But I want to remind you that fundamentally nursing and medicine are two different kinds of clinical practices. So it's not possible for us to use the exact same words. The things that nurses manage in patients, the human response to development, illness, or challenge, are quite different than what medicine and physicians treat, the fundamental pathologies, for example. So it is futile to call and to ask and to insist that nursing and medicine should use the same words, when in fact we're bringing two different perspectives into the care of a patient. What's important is that we understand the vocabularies are sometimes different and develop respect for each other's terminology and understanding what it means. Now, I could see that those of you who had done some readings and had thought a little bit about the readings seemed to manage the material quite a bit better than those of you who had not done the readings. And so I want to urge you again, please, there's 3 or 4 chapters to read for each week. It's critical that you read and reflect on them, maybe do a little additional reading for terms or concepts that you don't understand, so that you're able to keep up with this rather fast-paced class. Now, second, it's Friday morning, it's 20 past 10, and so I want to let you know that I've received most of the proposals for today. I've started to read them. They're really pretty exciting, and I'm really looking forward to going through the whole group. If you have not, by the time you're hearing this video, submitted your proposal, please get it in as quickly as possible. This will help me understand how to guide your learning over the next couple of weeks. I will be getting back in touch with you all as quickly as possible. Ideally by this evening, you should have feedback on the website, and you will receive a specific email from me if your team is one of the teams that's going to be picking up the iPad and working with the iPad starting on Monday. Now, let's move on to the objectives in the class for the next week of our course. Next week, beginning July the 16th, we're moving into a set of clinical applications that are consumer-focused, person-focused, the use of information technology to reach every individual person, sick or well, who's in need of nursing care. We're also at this time going to be introducing the concepts of human-computer interface or human technology interface. Not because this is relevant only to consumers, but because this is a really critical part. Thinking about how a technologically delivered nursing care can be received by a patient really requires that we understand how people interact with technology, both physically, can they touch a keyboard or move a mouse, as well as cognitively, how do they frame health and health problems. The concepts of human-computer interface or human technology interface will actually be used again later on during the summer course as we go through the conversations about clinical applications, special purpose systems, but we are going to focus on them specifically during this week. So you have 3 chapters to read for this week, Chapter 14, Human Technology Interface, and Chapters 19 and 20. These are going to form the cornerstones of what we consider technology-enhanced patient-centered care. Technology-enhanced patient-centered care draws on the key concepts of informatics, language and terminology, technology, humans, and formalizations. These key concepts that we use help us to understand how to build computer systems that make the best use for individuals. But let's first talk a little bit about patients, who they are, and what they're trying to do. I like to use the acronym SMART to think about patients, and the acronym SMART brings to mind the idea that patients are often self-assured, motivated, aware, responsible, and tolerant of technologies as we try to bring them into their lives. We're asking people to take care of themselves more and more. In the last 20 years, the focus of care has moved progressively from institution-based, professionally driven care to community-based, person-centered care. And that has done a lot of shifting in our structure of giving patient care, and also shifting in our roles as professionals, and importantly, shifting in the role of technology. As you think about patient-centered care, I want you to be thinking about where the individual is in their everyday lives. Are they at work? Are they home? Are they at school? What capabilities they have, what they bring with them, their knowledge, their willingness, their skill set. I also want you to think about what fears a person might have, what anxieties they might feel, what does illness mean in their lives. For those of you who are interested in exploring these areas, I call your attention to an old book by Susan Sontag called Illness as a Metaphor. It's a beautiful book that really describes from the patient's perspective what it's like to have cancer and what metaphors she uses for describing this. Understanding that illness, wellness, care mean very personal and idiosyncratic things to an individual will help you overall better understand the phenomenon of patients, as well as better interact with them for those of you who are going to be being in care providing facilities. Now, generally what we know about patients is that they tend not to be patients most of the time. The experience of going into the hospital or clinic is a blip in their lives. Now, while we think it's their whole moment, their whole lives, and they must be very concerned about this, often a patient who may, even when they're well, see 4 different clinicians a year, thinks of us as an interruption in their daily living. Even people with complex illnesses like cancer or heart disease still consider the care experience as something that only interrupts their living experience. So as we as nurses and those of us who are studying nursing and health informatics this summer approach the issues related to patients, I want to have you strongly understand that we're talking about people who have complex, busy, beautiful lives, and that health is only a part of it. We have a tendency to narrow in and assume that people should understand that health is the most important thing and they should behave as we would like them to behave. In my work over the last 10 years, I've been focusing a lot on a concept called personal health records. Now, personal health records were originally viewed as a window into the patient's medical record, but we've worked very hard over the last 10 years to help clinicians understand that personal health records are also a window into a patient's everyday life, and are also, most importantly, tools that should help a patient drive to action. So we've used concepts from human-computer interaction and design to try to bring forward tools that would be useful to patients, and we've used various studies to try to understand what is it that clinicians want to know about patients' everyday lives, and what do patients want clinicians to know and want them to share. As you look through the Project Health Design website that I encourage you to look at this week, you'll see not only videos that describe various applications, but you'll find resources that can help you understand some of the ethical issues, certainly some of the legal issues. Are we able to send information to a patient over a cell phone? Is it okay to use a smartphone to take pictures of a wound and send it off to a busy clinician? Who makes a medical record when we have sensors in the home that record whether or not a patient has taken their medication? All of these questions also pertain to the design and use of clinical information systems in the workplace, but they take on a very special meaning when we're talking about building tools for patients because of two key things. First of all, the patient is in charge of their life. The patient is the expert in their everyday living. So the tools should support that person's drive towards health, not a clinician's view of what that patient needs to do to be healthy, but that person's drive towards health. Second, we have to remember that these are unpaid people that work in or live and carry out their health work in a whole variety of settings. And if we want to engage patients in the health process, we need to be sure we understand where they live, what their motivations and distractions are, and how to effectively bring technologies to them. So for that reason, I've linked these three chapters together. Chapter 14, which discusses the human factors or human technology interface. Chapters 19 and 20 that talk a little bit about telemedicine and consumer health information. So now I'm going to give you an overview of what you need to be paying attention to in these chapters and what's important. Those of you who've read ahead have probably already figured out that a lot of the work for option 2, the X Prize challenge of either designing or testing an application for using an iPad, we have found that we drew a lot of our information from what's built into the Human Technology Interface chapter. Here you get an introduction to the fact and the idea is that we interact with technologies in a lot of ways. It's not just a person sitting down at a keyboard typing away, but there might be that sensor in your car that alerts you to the fact that you've got a problem with your engine. Or it might be a sound that's emitted from your cell phone as a call comes in. It may be the sounds that come off of the monitoring system in a hospital alerting you to the fact that a patient's EKG rhythm has changed, their cardiac rhythm has changed. There's an increasing number of ways to interact with technology through all of our senses, through motion and gesture, the way we do with iPhones, through vision and touch, the way we sometimes do with keyboards, but also think about touch-sensitive surfaces and some of the different kinds of clever technologies you see coming into everyday life, for example, at ATM machines. The core concept in human technology interface is to understand the user. And your text talks about user-focused design or user-focused work. User-focused meaning that we keep our eye always on the person who is the ultimate user of the technology. Now, as many nurses know, sometimes it's not one person, but it's several. It's a mom and a kid, or a caregiver and an elder. So the design of human-computer interfaces for the healthcare uses may in fact not be directed towards the identified patient, but towards the person who's caring for the identified patient. This raises issues, for example, of confidentiality, data security, authentication, that also become important as we begin to think about applications in the home. Some of you are thinking about building an iPad that will allow patients to respond to a set of questions and do a preliminary assessment before they come into a visit. I want to be sure you've given some thought to the ideas that say, how do you know what patient that is? How do you know, in fact, it was Mary Smith who actually responded to those questions and not Mary Smith's mother or sister? And most importantly, how do you know that that information was sent in a secure fashion? Capturing something in an iPad and transferring it by some cable or some wireless to an electronic record system opens up many points where security could fail. So as we're thinking about the user-centered practices, we have to think about what's important to the user. In our work in Project Health Design, we went into homes and we suddenly had to realize that the concept of data security, which we often think of as security between where I send information and where it's ultimately received in a clinic, is so different when we're in people's households where the data security might mean my mother can't read over my shoulder. Now, in the Human Technology Interface chapter, you're exposed to 3 different ways to focus on the user, to task analysis, to cognitive task analysis, and to cognitive work analysis. It's important that you begin to understand all 3 of those, especially those of you who want to design something, because they are the strategies that you will use to understand what tasks you're going to be supporting. Chapter 14 also has a very nice description of the design process, and this will be extremely useful in those projects where people are going to be using design or creating design structure. Formal evaluation and the descriptions of formal evaluations of computer technologies will also be of benefit to most of you. Pay particular attention to Figure 14 and also to the concepts of heuristic evaluation, which I think are most likely to be the most relevant and most important ones for you. You may actually want to peek into Chapter 15. We're not going to be spending too much time on Chapter 15 this semester, but there's some really interesting, nice descriptions of both innovative technologies such as RFID and retinal scanning, biometrics identities, but also some interesting information about security and security threats that you could find helpful. In the telehealth chapter, you're introduced to the use of technologies to deliver care remotely. Telehealth is a broad concept that refers not only to clinical information technologies reaching into the home, but also point-to-point clinical communications and information technologies that allow the expertise of a clinician in one place to be delivered remotely to another place. Think, for example, of teledermatology, where a dermatology expert here in Madison could provide consults to a small clinic in northern Wisconsin by having a video capture camera at the far end that sends images of a leg wound back here to Madison to be examined. Telehealth was a phrase that emerged during the 90s with the drawn from the ideas that it was a health application of telecommunications technology. This has largely been supplanted by the concept called e-health. E-health refers to a broad set of electronic technologies to either exchange data or exchange information or support the process of care. In my own area, telehealth clearly means telehome care, but that's not the only application of it. I want you to pay particular attention to the telenursing section, even those of you who aren't nurses, and I want you to look very closely at figures 19.2 and 19.3. These describe protocols for home monitoring. Clinicians, you can look at this and see, would you agree with these protocols? Do they fall within your practice? Does this make sense to do for a patient? For those who are not clinicians, I want you to think about, how is this data captured? Where should it be captured? How do we organize this? Should it be part of the clinical record, or is this simply a step along the way and we should simply put into the clinical record a summary or a monitoring of this system? The case study that's offered here is also pretty interesting and will help you understand a lot of the key issues about telehealth and how telenursing can be used to support patients with very complex disease. Chapter 20 addresses consumer health informatics. Now, this largely takes the argument of educational approaches to consumer health informatics. If you ask me, it's a little dated. If you think about the Project Health Design videos and the consumer health informatics information, we've moved on a little bit, not simply creating websites where people will sit down, maybe enter self-monitoring data or learn things about taking care of themselves, but we've also thought about a whole range of mobile technologies, and that's what we'll be talking about in class. What's important from Chapter 20 specifically are two aspects that tie back to Chapter 14. The first one is designing with the patient's skill set in mind. That means designing with the goals that a patient has for what their own health is, designing with their level of motivation, their level of anxiety or fear, their level of supports around them. Design should be driven by what we anticipate a patient to be. Now, I think a lot of you will find in your activities under Field Project 1 that many health-related websites are still designed with a very idealized view of a patient. A person has plenty of time, lots of assistance, and is very willing to participate in our care directions. Some of you who are a little more savvy realize that that's not always true. So we also have to design for the patient who might be scared, maybe manipulative, maybe anxious, very reluctant to participate in care, or quite time-consuming, the other side of the smart patient. The last part of Chapter 20 that's important for you to begin to read about is health literacy. Health literacy is getting an awful lot of attention nowadays because of the amount of self-management individuals must do to participate in their care. And while technology can be particularly helpful in assisting those people to know what to do for themselves, if a person is unable to read, or if culturally they use a different set of concepts, or they believe that a different set of health practices are correct, or importantly, if they're able to read in their primary language but not able to read in English, a lot of our terms and a lot of our websites may not be useful to them. We're just at the beginning to understand how to robustly create technologies that reach a person at their level of literacy, that neither talk down to them nor address terms in ways that they don't understand. You'll have a chance to do that this week when you work on field project number 1. I'd like you to begin to get ready for class this week by doing the readings, of course, and also make sure you look through the Cochrane collaboration information, particularly to see if there's strong evidence of how to manage Crohn's disease with alternative and complementary therapies. We're focusing on the Crohn's disease approach specifically because our guest speaker this week, Nikolai Kayenko, is a gentleman with Crohn's disease who also has a high-tech career, and he has helped develop a set of applications to help patients with Crohn's disease manage their care. Now, I know it's tempting to want him to get into the details of the clinical problem, and you can spend a little time with him, but I'm asking you to use your conversational time with him next week to focus on the informatics issues. Some things you may want to ask him about is how important is data security? What happens to your self-tracking when you're too sick to record things? How likely is it that your doctor really wants to look at all this information? Think and focus hard on the informatics aspect. Secondly, in our class discussions this week, we're going to be focusing in our small group discussion on 2 aspects. One, on looking at project health design materials as a springboard to think about mobile applications and to think about a novel approach to design called open source distribution of software. Often software is built as a commodity. For example, systems like Epic or like Microsoft, companies build and own the copyright, own the proprietary software, and they control it. Recently, there's been a shift to ideas that are more open in the direction, saying we should expose the code for all of our software tools. This will allow other people to make them better or optimize on them. So I want you to spend a little time thinking about not only how do we build and deliver clinical information to patients using technologies, but are there different ways we could actually build technologies using new approaches to software development that might be particularly helpful here. Remember, our class will be Tuesday evening. We'll have a guest speaker for most of the class and some time for small group discussions. You should be hearing from me over the weekend with your papers, and I wish you good luck in your preparation. Keep on reading and keep on thinking. Bye now.